There is a persistent myth in the mental health community that all ADHD medications are essentially the same, that it's just a matter of picking a brand and hoping for the best. Clinically, that couldn't be further from the truth. A short-acting methylphenidate and a long-acting prodrug amphetamine interact with your body in completely different ways. The trial and error approach that many patients endure is often a result of ignoring the specific pharmacokinetics of these molecules. If you've struggled with side effects, heart palpitations, or that dreaded zombie-like feeling in the past, it often wasn't the medicine itself. It was likely the wrong molecule, the wrong dosage, or the wrong delivery system that didn't align with your metabolic rate. Hi, I'm Dr. Shauna. I'm a board-certified psychiatrist, and today we are moving past the myths to perform a deep dive into the clinical science of ADHD medications. We're going to look at the data so you can understand exactly how these treatments work. Let's get into it. The foundation of stimulant treatment rests on two primary chemical families, amphetamine-based and methylphenidate-based medications. While they both target dopamine and norepinephrine, they do so in different mechanisms of action. Amphetamine, such as dextroamphetamine or lisdexamfetamine, work by both increasing the release of these neurotransmitters and blocking their reuptake, essentially opening up the tap while plugging the drain. Methylphenidates, like dexmethylphenidate, primarily work by blocking reuptake alone. Clinically, about 80% of patients will respond to one of these two families, but many have distinct preference based on their unique receptor sensitivity. If you've tried one of these with poor results or harsh side effects, it doesn't mean stimulants won't work for you. It often means we simply need to switch the chemical family entirely to find the molecule that aligns with your brain chemistry. Once we identify the right molecule, we have to decide on the duration of action. This is where we balance coverage with flexibility. Short-acting medications usually last 3 to 5 hours. These are excellent for targeted tasks like a specific project, but they often lead to a rebound effect, where symptoms return sharply as the medication clears the synapse, often causing irritability or fatigue. Long-acting or extended-release formulations are designed to last 8 to 14 hours. For most adults, a long-acting base is the gold standard because it mimics the natural rhythm of dopamine production. It provides a smoother ascent in the morning and a gradual descent in the evening, which help maintain executive functioning throughout the entire workday without the emotional roller coaster often associated with immediate release tablets. Not all long-acting medications are created equal. The delivery system is what defines the actual patient experience. For example, the Oro system used in some methylphenidates is an osmotic pump, a hard shelf that uses internal pressure to push medication out slowly through a laser-drilled hold. This ensures that the dose is released at a constant rate regardless of your digestive speed. Others are prodrugs, meaning the medication is inactive when you swallow it. It only becomes active once it hits your bloodstream and enzymes in your red blood cells break the lysine bond. This delivery method is one of the smoothest available in modern psychiatry, as it relies on an internal biology rather than digestion, making the focus feel more natural and the eventual wear-off much less jarring for the patient. We also need to discuss the crash, or the pharmacokinetic descent. When a medication wears off too quickly, the sudden drop in dopamine can cause fatigue, brain fog, or a spike in emotional dysregulation. To solve this, we use titration logic. We start at the lowest possible dose and slowly move up until we find the therapeutic window, the spot where focus is high, but side effects like anxiety or suppressed appetite are low. If you experience a crash at 4 or 5, we don't always increase the primary dose. Sometimes the clinical solution is to add a small booster of a short-acting medication to bridge the gap until bedtime. This customized titration is why consistent communication with your psychiatrist or mental health provider during the first 30 days is absolutely vital for long-term success. For some, stimulants are not an option due to side effects, medical history, or personal preference. This is where non-stimulants become our primary strategy. Alpha agonists like guanfacine and clonidine were originally blood pressure medications, but they are highly effective at quieting the physical hyperactivity and emotional impulsivity of the ADHD nervous system. Then we have SNRIs like atomoxetine. Unlike stimulants, these take 4 to 6 weeks to reach full efficacy because they require the upregulation of your receptors, but they provide consistent 24-hour coverage. These are often the superpower for patients struggling with severe rejection sensitivity or those who find that stimulants interfere too much with their sleep or heart rate. One of the most overlooked tools in my toolkit is your family history. ADHD is highly heritable, nearly 70 to 80%. If you have a sibling or parent who had a miracle response to a specific medication, there is a statistically higher chance that your brain will respond to that same molecule. We are essentially looking for genetic markers in your family's pharmacological history. Similarly, your own past responses is a vital data point. If you look at a medication 10 years ago and it made you feel zombie-like or flat, that tells me that your dose was likely too high or the chemical family was wrong for your receptors. We use this history to triangulate the exact dosage and delivery system that gives you the benefits of focus without blunting your personality. Before we ever write a prescription, we must conduct a thorough cardiovascular risk assessment. Stimulants work on the nervous system, meaning they mimic the body's fight or flight response, which can increase heart rate and blood pressure. We must ensure that there are no underlying risk factors for cardiovascular disease or stroke. If a patient has a history of arrhythmias, structural heart defects, or uncontrolled hypertension, we must be extremely cautious. Safety is non-negotiable in psychiatry. Often a baseline EKG or a consultation with a cardiologist is necessary to ensure that better focus doesn't come at the cost of your long-term heart health. In these cases, we frequently shift our focus toward the non-stimulant options we discussed earlier, which have a much lower impact on the cardiovascular system. Medication provides the floor, but your lifestyle choices provide the ceiling. Even the most advanced delivery system will fail if you're chronically sleep deprived or malnourished. High-protein breakfasts are clinically shown to assist with the synthesis of dopamine, which provides the brain with the raw materials it needs to stay focused. Conversely, high-dose vitamin C or highly acidic juices in the morning can actually interfere with the absorption of certain amphetamine-based medications, leading them to be less effective. We have to look at the whole picture: hydration, protein intake, and sleep hygiene to ensure that the medication can do its job. If you aren't supporting your brain's basic biological needs, you're essentially fighting against the very medication intended to help you. My clinical advice for you is this: treat the first month of any new medication like a controlled science experiment. Track your on time, your off time, your appetite, and your heart rate in a daily log. Medication is not a cure for ADHD, but it is a powerful tool that levels the playing field, so your natural strengths and superpowers can actually be utilized. When you find the right delivery system and the right molecule, the mental chaos finally settles into clarity. If you found this clinical breakdown of ADHD medication helpful, make sure to like and subscribe for more evidence-based mental health content. I want to hear from you in the comments. What has your experience been with finding the right balance? I'm Dr. Shauna, and I'll see you in the next video.